My name is Dr. Yusra Al-Mukhtar. I'm an aesthetic practitioner here in the United Kingdom. And I'm delighted to join you. It's morning my time, so I have my morning coffee, which I'll be sipping on throughout. And we're talking today about menopause. We'll be discussing fat loss and low-level laser technology. So these are my disclosures. After qualifying as a dental surgeon, I also qualified from Imperial College London in medical sciences and healthcare, how to run healthcare organizations. I have a background in maxillofacial surgery, which I did for 4 years here in the UK in various different trauma units before moving into private practice, leaving the NHS and doing oral surgery and facial aesthetics. I've got over 14 years of experience, and I have a clinic here in Liverpool, which is where I am at the moment, and also in the heart of London. I am a key thought leader for Galderma and Mertz, KOL for Cutera, Obagi Medical, and Erconia lasers. But what I'm going to speak to you about today is my knowledge, my experience, and I only align myself authentically with treatments and brands that I truly believe in. I've helped to set up a patient wellness committee here in the UK, which is looking at how we can support our patients in terms of holistic health and well-being. And I'm a researcher in psychology for facial aesthetics. We have a psychologist in our clinic and a psychiatrist, and we're very passionate about supporting patients on their aesthetic journeys, but holistically. And I do a lot of non-surgical rhinoplasties. I was very humbled and honored to have been awarded Best Aesthetic Practitioner in the UK, but I think that there are better practitioners than me. Next, please. Thank you. So I'm going to tell you my story and my journey and how and why I started out in what I call holistic aesthetics, which I think as an industry as a whole, we are moving rapidly away from being an industry focused on vanity to being an industry focused on wellness. Now, my journey started when I was 19 years old. I was a third-year dental student, and I was diagnosed with an autoimmune condition called polyarthritis. And I was hospitalized for it. It was acute. It was very bad. It was severe form. And initially, I was diagnosed with septic arthritis and then lupus before they settled on a diagnosis of post-streptococcal polyarthritis. It was exceptionally difficult. I couldn't dress myself. I couldn't undress myself. I couldn't bathe myself. I couldn't go to the toilet by myself. I became completely reliant on others to help me do every small, minute function. And my body basically just said no. And I think it was post-streptococcal arthritis is instigated by a bacterial infection. And it results in acute and severe inflammation of the joints and can sometimes also affect the heart. And that resulted in a decade-long treatment of my symptoms with steroids and painkillers. And that resulted and culminated in me being diagnosed with osteoporosis at the age of 28 and told that I could not have children, that I should not birth because the osteoporosis was in my lumbar spine, and that I should now start bisphosphonates. And that was a real life-changing moment for me because I had taken the steroids, sometimes injections, sometimes oral, to function as a student, then to function as a newly qualified physician, then to function in a trauma hospital and surgery. And then suddenly to be told I had to start bisphosphonates and that I couldn't, have children is probably the hardest thing that any woman can hear. And I came to the realization that I couldn't actually rely on traditional medicine anymore because I felt a disconnect. And I remember when the doctor told me, you need to start bisphosphonates, I actually burst into tears in her office. She handed me some tissues. We have 10 minutes per patient here in the UK in the GP's office. Not their fault. That's just how the NHS is run. And she said, so shall I write the prescription? And I made a decision that I needed to look elsewhere and find another solution. Because by 28, I had arthritis and I had osteoporosis, and I was riddled with pain and inflammation and dysfunction. And I felt like a young mind trapped in an old person's body. And I felt hopeless and helpless and depressed. And I cried myself to sleep for many, 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 many weeks. Until a good friend of mine told me to go and meet a wonderful doctor in Harley Street. And he gave me something that nobody ever gave me before, which was time and hope. And he told me to watch a documentary called The Connection. And this really changed my mindset, opened my eyes to alternative treatment options, and made me realize that we cannot attempt to understand the body in isolation of the mind, and we cannot treat the mind without understanding the body. We are interconnected. Every single cell in our body talks to each other. Every part of our body talks to each other. They are not isolated little features or beings or organs. The health of one part of the body is directly and reliant on the health of our body as a whole. And I think as medical professionals, we have become so fantastic at looking at specific areas of expertise in great detail. But what we have maybe lost in our medical training and in general practice, I think, has, particularly when you become hyper specialized, whether that's maxillofacial surgery or ENT or colons or whatever it may be that you do, cardiovascular health, I think we have become hyper specialized on areas and stop and we don't take a bird's eye view of a patient as a whole and try and connect the missing pieces or the dots to understand what may be causing a pathology. And instead, we're looking for a set of diagnostic criteria to understand a set of symptoms. And then based on that, trying to find a solution or a treatment. And I just don't think that's good enough anymore. And so I'm really passionate about taking a holistic view to health, wellness, and aesthetics. So I've been talking about this for the last decade, sort of since I started my own journey in healing. And I can say after being on steroids for a decade and being reliant on them to function, I have not taken any painkillers. I have not been in any pain. I have thankfully not just survived, but thrived. And I had 3 children and I birthed 2 of them in a water pool. So my messaging is there is healing outside the scope of traditional oral medicine. And I think it's incumbent upon us to explore those and understand them and support our patients holistically. So my passion and my journey has taken me, we pivot, don't we? We go through life and we have different phases in our lives. And I've grown with my patients over the last 14 years. I have known them for 14 years. I've held their hands from when they first met their partners, to when they were considering marrying them, to when they had children, to when they've gone through the perimenopause, menopause, and sometimes gone through divorce. And I started over the last few years to see patients having a recurrent, repetitive, predictable set of symptoms when they were coming into my clinic and talking about them, often in tears, but feeling very, very alone, feeling like they were the only people on planet Earth that was going through this. And it was the perimenopause, not the menopause itself, but the perimenopause. I'm going to talk to you about what that actually is. And so my 9 a.m. patient would come in and be a little bit reserved. You could see that she was upset, holding back. What had brought her in was a reduction in her confidence and self-esteem and her desire to seek care, be that aesthetic or body care. She was starting to see changes in her body, but she was suffering at home. She wasn't sleeping. She had insomnia. She had brain fog. She didn't feel her best self. She was fighting with her partner. She was irritable with her children. And she didn't understand herself, and nobody around her understood her either. And often she would go to the GP, and the GP would give her antidepressants and say, here you go, love, here's some antidepressants, crack on, take them and keep going. This is just normal, And thankfully, we have come a long way from then. And whilst depression is one of the recognized symptoms of menopause, it is a symptom of a cascade of physiological changes. And previously, patients going to see their healthcare professionals were really being treated as a set of symptoms, as I say, and the source of the problem was not being looked at. And there was no real understanding of the psychosocial impacts of age-related skin changes. And so I threw myself into research alongside a doctor, a clinical psychologist called Dr. Lindsay Hampson, and psychiatrist Dr. Hassan Yassin. And we assessed the psychosocial impacts of age-related skin and body changes on patients' well-being. And we took particular interest at looking at what was going on in the menopause. So let's talk about the menopause. The menopause is a normal physiological transition that every single woman will go through, and it is when a woman's period stops altogether. And it's a retrospective diagnosis. That means that we wait until after the patient hasn't had a period for 12 months, and then we can confirm a diagnosis of menopause. The average age of onset here in the UK is 50, and it's estimated that 15.5 million women in the UK are in the menopause transition at any one time. That is 23% of the UK population. That is a huge proportion of our population are going through this transition. And it's really important that we understand this. And I think, thankfully, the conversation has changed and we've come on a long way, and the stigma has gone regarding empowering women with choices of what treatments they may wish to take on or not take on, but ultimately being informed of all the treatment options. Now, the perimenopause is an area the start of the transition, so to speak, and it starts 10 years before the actual onset of menopause. So what doesn't happen is that women go through the menopause and they stop getting their periods, and their estrogen is all depleted and their testosterone is all depleted, because testosterone is a female hormone too, and they just age overnight. That's not quite what happens. What does happen is that there is a slow and gradual decline, actually starting from the age of 35 in terms of estrogen and testosterone, with a reduction of testosterone of about 1% a year. And that results in a whole range of physiological, functional, physical, mental, psychological, and aesthetic changes that may drive our patients into our clinics, but it's really important that we understand what is going on as a whole. And as aesthetic practitioners, I often hear people talking about the skin-related changes with menopause. Women are going to lose 30% of their collagen. Yes, actually, we're losing collagen from the age of 25. Our peak is 25. And then we start to lose collagen at a rate of about 1% a year. And then it's estimated that that starts to increase from the age of 35 due to that slow and gradual decline in estrogen. And then in the perimenopause, so the 10 years before the menopause, in that decade, is the fastest rate of biological aging or accelerated aging and collagen loss. So we have 30% collagen loss. It's said to be 3% year on year. Loss of elastin. Of course, collagen and elastin are two different proteins that have two different functions, and loss of hyaluronic acid. But that's really not all. Now, women who come to see me, when I start to open up the conversation, because they say to me, I'm just not sleeping well, I want to kill my partner, I'm not interested in intimacy anymore, I've got brain fog, I can't finish my sentences, I don't feel confident, I've put on weight around my abdomen, I'm riddled with anxiety, my hair is falling out, my body is getting out of control, I'm trying to lose weight and I just can't. They say, oh, but I'm not going through the menopause because I don't have hot flushes, I don't have night sweats. And that seems to be the layman, the general public's associated symptoms, understanding of the associated symptoms of the menopause. And most people don't even know what the perimenopause is. And actually, what we now know is that these are all the changes that are occurring. There's 48 different recognized symptoms of the menopause. And women can start to experience these changes in their late 30s. And I'm talking recurrent UTIs, nausea and digestive issues, changes in breast size, lack of motivation, sleep issues, overwhelming anxiety, mood swings, yes, the changes in the skin texture that we know about, panic disorders, acne, dizziness, bloating, hair loss, brain fog, heart palpitations, body odor. I see this a lot, women coming in saying, I don't know what's happened, but I've got a lot of BO that I didn't have before. Muscle tension, vaginal dryness, loss of bone density, fatigue, and so on. And now what we know is, and there was a recent study published on the 14th of August that looked at biological aging, and we now know that actually, yes, there is a slow, gradual decline in our hormones, but there is a significant transformational change where we are aging rapidly from a genetic point of view at the age of 44, and 60. And this seems to be in line of when people are coming in with their symptoms. And I'm going to talk to you about the hallmarks of aging as well, so that you can understand what is actually going on. So when there are these hormonal fluctuations and you're not sleeping well, you've got poor sleep, you've got brain fog, you've got irritability, stress, low energy, that impacts everything in a woman's life. That impacts her personal relationship, that impacts her communication style, that impacts the intimacy that she may have with her partner. That may impact her self-esteem and her confidence, her desire to show up to work, her desire to even show up to life. And so what starts to happen is social isolation, which in turn accelerates biological aging and is actually a contributor to early death. So it's really, really, really important that we understand and take a bird's eye view of what is going on, so that we can support our patients and safeguard them from a decline in wellness, health being not just the absence of disease, but a complete state of physical, mental, and social well-being. I'm going to show you a video of one of the a couple of the ladies that we interviewed during this research study, asking them what brought them in, how the menopause affected them. It's just a short snippet, but it gives us a slight understanding of what else might be going on for them.
It will mean, I'm trying to get upset. Sorry. My mum's also went through the menopause as well, similar age. I think you start to lose yourself a little bit with children and work and things like that. So for me, it would mean so much. It would just mean the world to me to just be able to go out and just feel confident and happy. Sorry.
I think reaching menopause is that age where you've tried your best. I think you need more collagen in your skin. You're trying everything but nothing seems to work. You get to that age where there's no going back and it's not getting any better, so I need something to help. I've lost who I am and who I was, I think.
Literally, I think it was because I'm nearly 40 and I thought I don't want to go into another year feeling like this.
What began my journey was when I went through the menopause. I was looking in the mirror and I didn't like what I saw. The changes to my skin, to my face. I just wanted to start feeling a little bit better about myself.
To be able to look in the mirror and feel like I'm me again. I'm so down and don't want to go out. I don't want to be in company, or I don't want to be on pictures. That it's getting me down.
It crept on so slowly that over time I realised that the things that were happening to me were because of the menopause. Constantly tired, aching from head to foot, waking up tired, going to bed tired, stiff joints. I noticed I also get a little bit of arthritis in my fingers. Skin was looking more aged. The wrinkles were becoming more apparent, the skin was drier, sort of droopiness down here. It crept on so slowly, but then when I look back, I thought, I feel like I've just aged overnight. I've gone from this sort of what I felt was young, carefree, full of energy person to an elderly lady. I don't know, it just kind of came from nowhere. And at first I was putting it down to old age, and I thought, no, this can't be old age, because I didn't feel old. So I thought, now's the time to seek some help, and that's what I did.
Those are all real patients. Those are all my patients. And I'm so grateful that they contributed to this research study. And what I found really interesting and fascinating was each of them spoke about a reduction in self-esteem, confidence, wanting to show up, and were apologetic. They all ended the conversations with me saying, sorry, I feel so vain. And I really found, I think, these details are really important, because women are still apologetic and ashamed for seeking care. And I think it's really important that we work hard as a collective to break down those stigmas and empower people to unapologetically access care. Okay, so this research report, I called it the Menopause Skin Report. It was published in 2022. It was a research study where we surveyed over 2,000 women in the UK aged from 18 to 74. Why? Well, because some women go through premature menopause at the age of 18. and even younger. We had patients even younger who went through the menopause, and it's a very, very difficult and isolating time because they're going through hot flushes and night sweats and weight changes, and nobody knows, and they can't really talk to their friends about it. We spoke to women who had the perimenopause, menopause, and postmenopause. We asked them a whole range of questions. And I'm just going to show you small snippets of interesting facts I thought that we pulled up from there. 63% of women don't realize that the menopause, that signs of the menopause can take hold 10 years before their last period. And 80% said that they don't feel prepared for the onset of the perimenopause. 56% said that they feel fearful. So there's still a real fear, a fear about feeling irrelevant, about the changes that might occur, and really being not prepared. And so what I hope part of my messaging today will be is there is a space here to educate and empower women, because if you are prepared, if you know what's to come, then you walk into that next phase of life, not blindsided, but actually in the know. And then you can make an informed decision about if you want to take a passive or active approach in that time period. So, you know, I'm a big believer that knowledge is power. And I think that's a job for us to do. So the peri-scaries is what we called it. Peri-scaries were kind of the fear factors, what women were afraid of. They were afraid of loss of femininity, overwhelm, loneliness, and also no longer being deemed attractive to their partners. And so we asked them, what are the most, why are you coming in for skin treatments? What is it that you want? 41% said, I want to build my confidence back. 39% said they want to feel how they look and not older than their age. 35% said they just want to concentrate on their life and not worry about how they look. And that's all understandable. And then we took it a little bit deeper. We asked them about their mental and social well-being. And I found this really fascinating. Only 16% said they feel anger towards their partner. I will tell you, I think that is a gross underestimate. Every single woman that I see comes in and shares with me that she has uncontrollable, irrational anger. She has the insight. She knows she's being irrationally angry, but she can't control it. And I hear this from 9 a.m., 10 a.m. patient, 11 a.m. patient, 12 p.m. patient, on and on throughout the whole day. It's a very, very common feeling. And I think there's a little bit of shame in admitting it, but I think it's important that we admit it and that women talk about it and that men understand that they haven't just drawn the short straw and their wife is being crazy, that actually this is a physiological and psychological change that she's going through, and it can and will get better. And understanding may, in my opinion, help to keep people together rather than the huge number of breakups that I see in this period of time. 58% said that they generally lacked in confidence. 43% avoided looking in the mirror. 48% didn't want to go out, so they started to become more socially isolated. 51% said they didn't want to be in family photos, and 67% felt anxious and stressed. So this is relevant because mental and social well-being is relevant to every single procedure that we may do, because we're treating people and not features. So why are we getting these symptoms? What is going on? What's the science behind it? Well, yes, we know that we have estrogen, and it's really important that women recognize that they also have testosterone. And testosterone is a very important female hormone in regulating their libido, their energy levels, and also in maintaining muscle mass. And again, this comes down to educating patients about how and what they need to do in order to not just live longer, but live healthier. So estrogen itself is a female hormone that confers natural protection against a range of different diseases. It is neuroprotective, it is cardioprotective, it protects our brain, and it protects our bone density. And it declines after the menopause. We see a direct increase in the risk of cardiovascular disease, 13 different types of cancers, type 2 diabetes, stroke, sleep disturbances, and cognitive decline, which is more prevalent in women after the menopause. And studies have shown that peri- and postmenopausal women have an increase in abdominal obesity, triglycerides, total cholesterol, and fasting glucose and insulin resistance. So these are the 12 hallmarks of aging, which you may have heard of. This was first looked at and actually aging research has started in 1939. It's been going on a long time, where scientists have started to try to understand what is happening to human beings as they age. What are the changes that are occurring? Why do we need to know? Well, because if there are interventions that we can offer to these patients to slow the biological aging or slow down aging, then that is of benefit. And I'm not saying that aging is a disease, but I think we must face facts that with age comes an increased risk of age-related diseases, including neurodegeneration, cardiovascular ill health, cerebrovascular ill health, metabolic dysfunction, and so on. So this is not about lines and wrinkles or the aesthetic considerations of weight gain, but actually the health impacts. And the 9 hallmarks of aging, which were deemed cellular processes, so to speak, and changes that were found with aging, were first published about in 2009, and since then there have been 30,000 papers and research studies looking at aging. And there's a difference between biological and chronological aging, which I'll explain, but these are the things that happen. You get dysbiosis, which is a dysregulation in your normal microbiome, so the microbiota that naturally live in our skin, our mouth, our gut starts to change. You have genomic instability, you have telomere attrition, you have deregulated nutrient sensing, mitochondrial dysfunction, cellular senescence, chronic inflammation. There's 12 of them. And discussing each one in details beyond the scope of this presentation, but I think it's really important to understand. But what's really important to understand also is that none of these processes happen in isolation. So if you have dysbiosis, you have proliferation of bad bacteria, you're going to have chronic inflammation. Chronic inflammation accelerates telomere attrition and mitochondrial dysfunction, and so on. So everything is interconnected. So if we can help, and if we know that there are certain things that we can do to positively impact or slow down some of these processes, then what that means is we are improving our patients' health. So inflammation is the concept of accelerated aging with chronic inflammation. Now, inflammation as a whole is a natural protective process and response to injury or to infection. Your body responds to trauma or responds to infection by an inflammatory process. And that's fine, that's normal, that's good. That supports and empowers wound healing. But inflammation without the presence of infection or injury or low-grade chronic inflammation is dangerous. And what scientists have found consistently and repeatedly, is that there is a bidirectional relationship between inflammation and aging. So as we age, we are more likely to be in a state of chronic low-grade inflammation in the absence of infection or injury, and that accelerates biological aging. And if you are aging, you're more likely to have inflammation, and if you have inflammation, that accelerates aging. So there's this bidirectional relationship. And so inflammation is seen as a precursor for all disease, which means as medical professionals, we need to try and downregulate inflammation to reduce the onset of disease. And estrogen as a hormone has a potent anti-inflammatory effect. And you get the recruitment of this inflammasome, which is a multi-complex protein that is important in the cascade of wound healing, or in the cascade of inflammation, the inflammatory pathway. You get the activation of caspase-1 and processing of pro-inflammatory cytokines like interleukin-1 beta, interleukin-6, TNF-alpha, etc. And these pro-inflammatory cytokines can actually cause senescence as well. So senescence is the concept of cells starting to die off, starting to become dysfunctional, not being able to repair themselves. So there's a direct relationship as well with senescence. And where we have inflammation, often this inflammation actually travels. So it's not that you have inflammation locally. If you have an injury in your hand, you might have inflammation locally or inflammatory markers locally, low grade. If you have acute inflammation, we can often test and find that you have elevated inflammatory markers like CRP or ESR. But chronic low grade, constant infiltration of pro-inflammatory cytokines results in the infiltration of peripheral immune cells like T-cell invasion. And that means that you actually get inflammation in your brain. We call that neural inflammation. And everything starts in the brain. If your brain is inflamed and you start to get cognitive decline, brain fog, inability to show up, reduced sensory processing, reduced ability to retain information, reduced metabolic function, everything starts talking to each other in a dysfunctional manner. So this chronic low-grade inflammation is really a source of interest and importance when we're looking at downregulating inflammation, improving general health of postmenopausal women. And they found the presence of these multi-complex proteins, these inflammasomes, in the cerebral spinal fluid of postmenopausal women. And the research study that was recently published in August 2014, that showed that we age quite rapidly, and there's a transformative, significant impact at the age of 44, found that there was that people, men and women, so not just women, were in a chronic low-grade inflammatory state. So there's a difference between chronological and biological aging. Chronological aging you cannot control. That's the number of years that you've been on Earth, and every single day that we are here, we are aging. That's a privilege, but also a responsibility. Biological aging is different. That is the rate at which you are aging from the inside, and all aging happens at a cellular level. And it isn't dependent, as we once thought, on genetics alone. So biological aging is said to be, 80% of it is deemed to be due to your lifestyle. Only 20% seems to be due to your genetics. So if your mom aged well, people think, oh, well, I'll age well. Well, that might be nurture and nature. You might have picked up great lifestyle habits as well. But the great thing about knowing this is that we can change it and we can test it. We can see how well our patients are aging. And actually, last year, I did my biological age and during a time and period of stress, and I was older than my chronological age, which was a real killer for me to realize, but it instigated change. And I've tested again, and I've managed to reduce my biological age. So you can change your biological age. Now, recent studies indicate that menopause affects biological age significantly. And in the transition from perimenopause to menopause, women went through a mean change in biological age of 9 years in just 6 months. So it's really important that we understand the science, and as medical aesthetic professionals, I assume that the majority of you on here are medical aesthetic professionals, that we bridge the gap between aesthetics and wellness. And definitely our industry is going that way, certainly in this side of the world. But I think globally, we're starting to understand that what we do is not skin deep. And we have so much power to improve the lifespan of our patients. And it's important that we take a holistic approach. And it's important that we understand how other technologies can support our patients in their journey back to health. So I'm going to talk about something that I think a lot of people find maybe boring or don't understand. I find it fascinating. I find physics fascinating. I'm going to bring it right back to basics. What you're seeing right now on your screens is the electromagnetic spectrum. So this is a spectrum of different wavelengths of light and frequencies of light. Wavelength being the distance between two peaks on a wave. And the shorter the wavelength, the higher the frequency, like X-rays or UV rays or gamma rays. And where you have high frequency, low wavelength, this is on the electromagnetic spectrum, these are deemed to be more dangerous. We call them ionizing radiation. Ionizing radiation has the ability to cause ionization of our cells. So if you think of every single cell in our bodies, and every single thing is an atom, comes from right down to basics. You have an atom which has protons and neutrons and electrons. And an ionizing radiation has the ability to kick off an electron from an atom, creating an unstable ion, which can mutate and is dangerous. And we know this, we know about UV rays, and we know that our bodies are designed to absorb all forms of electromagnetic spectrum. We know that we can take X-rays. We know that when the UV rays hit our skin, we might not feel them, but they impose a photobiomodulation, and they can cause ionization. They can actually change the cellular structure of our tissues, of our cells, of our DNA. They can cause DNA to leak into the cytoplasm, called cytoplasmic DNA. They can cause DNA damage, and increase the risk of developing pigmentation, skin cancers, and so on. And then when it comes to visible light, I think there's almost like a bit of a confusion. Do we really absorb light? Well, yeah, actually we do. Every cell in our body almost kind of photosynthesizes. We absorb light and we respond to light in different ways. And I'm going to talk to you about that so that you can understand. And if I take it back to basics, if you think about when you're sleeping at night, there's no light in your room. You've got a hormone called melatonin, which is high. When the light starts to creep in through your windows, that light creates a photochemical change. So when any light hits the skin, you can have photothermal effect, like CO2 laser, for example, which sits in the infrared spectrum. We know that when we put laser on the skin, it's red, it tends to be red CO2 lasers, and it can create heat, which is used for resurfacing. So we know about how to use that type of light. We know that when we're sleeping, as I say, when the light comes in, our body absorbs that light, and that instigates a photochemical reaction and a biomodulation, which results in the upregulation of a hormone called cortisol, which wakes us up. Melatonin gets downregulated, and we start to kick into action. Our mitochondria starts to kick into action. But then there's a confusion about low-level laser light therapy. Does it work? Does it not work? How does it work? So I want to talk to you about that today, because what you're seeing in this wavelength is that there is energy being delivered as packets of energy that we call photons. And when a photon hits the skin, it either creates, like I said, a photochemical reaction, a photothermal reaction, or a photomechanical reaction. Think of a pico laser that hits the skin and causes a noise. Okay, it comes so quickly, it causes a photochemical reaction, resulting in shattering of a tattoo. That's called the photoacoustic effect. So what's a low-level laser therapy? Well, this sits in the visible light spectrum. And today I'm talking to you about the emerald laser, which is a 532 nanometer true laser. This is a non-thermal laser, so it exerts a photochemical impact. It photobiomodulates the body without causing heat. So it's non-thermal, it's non-invasive, there's no downtime, there's no pain, but it instigates a cascade of events in the body that results in pain-relieving properties. It optimizes mitochondrial function. There is an anti-inflammatory benefit. There's immune-boosting properties. It's neuroprotective, and this is being researched more and more. Downregulates stress and can be used for fat loss, but also reduction in cellulite because it upregulates collagen production. I'm going to talk to you about the science behind that. Because when I first saw the emerald laser, I'll be honest, I thought, this can't work. How is green light going to do anything? And that's where I got it wrong. This is not green light. This is not LED. This is a true laser that penetrates the skin, where the energy is transferred into a target chromophore that results in a biomodulating impact and a cascade of events that helps our patients. And low-level laser light therapy has been around for a really long time. It's being used now for treatment of ADHD and trauma care and improving Alzheimer's, cognitive function, reducing pain in patients with chronic inflammatory conditions. And has been used in skin rejuvenation because we know that it helps to optimize fibroblast production and proliferation. And so there's so much that this treatment can do. And indeed, emerald laser has 22 different FDA approvals. So it does what it says on the tin and more. So what are these mitochondria? If you remember from the 12 hallmarks of aging, mitochondrial dysfunction is one of the key 12 hallmarks of aging. Mitochondria are like these little organelles, which are like the engines of the cell. We call them the energy powerhouses. And they work very well, and they create energy for every single cell. This is not just relevant for humans, but animals as well. Everyone has mitochondria. And as we age, the mitochondria, the little engines, become a little bit aged and dysfunctional, and they chug along a little bit slower. So they kind of like an old car start to not work as well as they should. And when they don't work as well as they should, everything gets affected, because your hair cell, your brain cell, your eye cell, your skin cell, your heart cell, every single cell has mitochondria, and we need energy in order to function. So these produce energy via a cellular pathway. And as we age, we have a reduced number of mitochondria. The remaining mitochondria become inefficient, and you have an increase in damage by free radicals. And it's very interesting, but estrogen seems to enhance the effects, the work, the cellular pathway of mitochondria, and help to replace old mitochondria. So within mitochondria, you have an energy producing machine. This is called the electron transfer chain. And when non-thermal laser therapy hits, this is concentrated, coherent photons of energy are delivered to the cell. This results in a photochemical reaction, and it optimizes the electron transfer chain. Its primary effect is the cytochrome C oxidase, and it upregulates ATP production. That is what we need for energy, for function. And these little mitochondria are responsible for cellular function, immune response, and they help to control inflammation. And you may have heard about NAD+ or NAD+, that is now kind of gone global. A lot of us are on it, and is a key element in supporting mitochondrial function and downregulating inflammation as well. So we know through scientific evidence and recurrent research that NTL, non-thermal laser, can dampen inflammation, improve mitochondrial function, and optimize expression. There's so many research papers about this, and I would really encourage you to take a deep dive into it because I think it is absolutely fascinating. So let's talk about weight gain, which is a huge issue for men and women, and becomes a huge issue in the menopause because fat redistribution occurs in the menopause. So where premenopausal women's stomach fat accounts for approximately 5 to 8%, postmenopause, it accounts for 20%. So there is weight or fat redistribution. And we already are in a global position where there's a worldwide epidemic of obesity. And it's said that there will be 300 million people who are suffering with obesity by next year. So this is a real issue of concern, not just from an aesthetic point of view, but a health point of view. So let's talk about these fat cells. So fat cells are, God didn't give us fat to punish us. Fat cells are there for a reason. They have a metabolic function. They optimize our metabolic processes. They help with the processing of specific hormones, and also with the absorption of specific vitamins that depend on fatty acids. When you have, adults have a standardized set number of fat cells. So let's say God gave me 100 fat cells in my abdomen. I think he might have given me a bit more, but let's go with 100. When I put on weight, what happens is not that I grow new fat cells, but those existing fat cells expand. And a lean fat cell has an anti-inflammatory profile. It's doing its thing. It's an important cell that helps with mood regulation, hormonal balance, and gives an anti-inflammatory profile. When you have an enlarged, inflamed, or hypertrophic fat cell, that happens when patients are overweight or obese, they start to release pro-inflammatory cytokines, TNF-alpha, interleukin-6, interleukin-1 beta, and you get metabolic dysfunction. And this, of course, we know results in insulin resistance and a whole cascade of events that increases the risk of patients developing cardiovascular disease, Alzheimer's, and so on. So menopause itself, because of the estrogen, when we go through the menopause, you have a reduction in fatty acid oxidation. This is one of the largest contributors to ATP production. It accounts for 40 to 60%, that cytochrome C oxidase that we were talking about. When you have a decrease in fatty acid oxidation, you get an accumulation of lipids that the body just can't burn efficiently as a fuel source. And you start to get an increase in visceral fat, fat in your organs, fatty liver, and so on. Now, the emerald laser utilizes NTL, non-thermal laser, to increase ATP production by the transfer of energy to these through this electron transfer chain, and optimizes mitochondrial function, downregulates inflammation, and helps with the metabolism of accumulated fatty acids. And what they have seen is that you have an increase, you have a release of fatty acids and triglycerides from the fat cell, which I'll show you. Now, there's a number of different options available for fat reduction. We've heard about cryolipolysis, fat freezing. You can use HIFU. You can use radiofrequency to deliver heat that can result in apoptosis. And photochemistry or photobiomodulation is where we're using non-thermal laser. which does a number of different things. It emulsifies the fat within the fat cell, it optimizes the mitochondrial function, it downregulates inflammation, it creates a transitory pore within the cell wall or the bilipid membrane of the fat cell. And it's important to understand why we are moving away from liposuction or cryolipolysis. Part of that may have been because of bad press, and bad press, bad news makes news. But what researchers have found is that removal of subcutaneous fat can result in the accumulation of visceral fat. And this has been shown in liposuction. And this is called overcompensation. We don't know to what extent it happens with cryolipolysis or other procedures, but it certainly happens to some extent with surgical liposuction, and lifestyle factors can help with that. But now we want to see how we can retain the fat cell, but optimize its health, reduce its inflammation, and reduce that hypertrophy. So adipose hypertrophy is essentially when that fat cell becomes enlarged and causes dysfunction. And as I said, NTL increases ATP production, and you get small bursts of reactive oxygen species and induction of transcription factors, which is why you also get cell proliferation and migration and improvement of fibroblasts, recruitment of fibroblasts, and the cellular function of fibroblasts, which leads to improved collagen, which is why the emerald laser is also FDA approved for cellulite, because while they were treating for fat reduction and health improvements, they started to see that there was collagen remodeling and an improvement in the overall skin quality. So you get how it works. Part of it is like I said, via that electron transport chain, and part of it is through the fibroblast recruitment, and part of it is also through gene activation, where you get this transitory pore, a pore in the bilipid membrane, which stays open for about 48 to 72 hours. The contents of the fatty cell, the fatty acids, the triglycerides, then are evacuated, leak out of this little pore, and moves into the interstitial space and is absorbed by the lymphatics. And you have filtration via macrophages. You can see this on a histology. You can see this on microscope, where these are the fat cells, and you can see the bilipid membrane. This is the disruption in the bilipid membrane, the emulsification of the fat cells into fatty acids and triglycerides, the evacuation of them, and the cell structure becoming then optimized to becoming a normal size cell. And this has been clinically proven time and time again. There have been a number of double-blind, placebo-controlled trials that have looked at the efficacy of non-thermal energy, a non-thermal laser using a 532 green diode laser. This emerald laser has 10 diodes. It's a true laser, as I said, so it penetrates the skin and the fats. In patients who had 2 treatments a week for 3 weeks. Initially, this was FDA approved for patients with a BMI of 30 and under. It has now been approved for patients with obesity, so those with a BMI of up to 40. And they saw significant reduction in mean total circumference measurements, time and time again, with an average 4.5 inch loss. And if you know Erconia, you know that they first started off with low-level laser therapies using red light, so lasers in the red light and the electromagnetic spectrum. And that was also efficacious and also resulted in improvement in inflammation, pain reduction, and reduction in the hypertrophy of the fat cell. But when they tested with green laser, because of the difference in the wavelength, you have actually more photons of energy being delivered per unit. And so they found it to be 30% more, approximately 30% more effective. So on average, there was 4 inches of fat loss seen, which is approximately about 5 pounds of fat. And if you're looking at successful liposuction, most successful liposuctions evacuate 2 to 3 liters of fat. So this is what I would say is an alternative. But it's important that we explain to our patients, you're not going to get surgical results. This is an alternative. You can use it as an adjunct, and actually non-thermal laser was used pre-liposuction and facilitated the efficacy and treatment outcomes of patients who were undergoing liposuction because they found that the fat was liquefied and easier to remove. And that's how they then moved on to seeing, well, actually, how are patients, what kind of results are we getting if we're using non-thermal laser without surgical intervention? Some patients might want surgical intervention and some others may not. So this is an alternative and an option that we need to know about. And ultimately, science has proven works and works very well. And this is actual fat loss. So this is not fat loss or reduction in circumference because of body wraps or so on. And so more recently, as I say, in 2016, they received the FDA approval for patients with a BMI of 40, and you can read the reference of studies where they were done with randomized double-blind placebo-controlled trials with the diode laser, 532 nanometer diode laser with 10 diodes, treating patients in the hips, waist, and upper abdomen, and they found that patients also had significant reduction of 5.99 inches of circumference on average after treatment, and that these results were sustained. But it's important, again, that we're advising our patients about lifestyle change. So there are many different publications. I put some of the references, but if you want, you can contact me and I can send you more, or you can contact Erconia and they can send you more. But one of the most interesting things that we're seeing is, because we're not evacuating the fat cell as a whole, we're not killing the fat cell. This is not cryolipolysis. Cryolipolysis is an effective treatment. I got cryolipolysis in my clinic, and it's an option that we offer to our patients. But cryolipolysis, as an alternative to liposuction, we know that the removal of fat cells from the body results actually in some kind of metabolic dysfunction. Patients start to get mood dysregulation, anxiety, sometimes depression, and though that can be regulated and normalized after some time, and with lifestyle factors, we know through scientific evidence that there was some extent of compensation with an increase in visceral fat after liposuction. So liposuction was removing the subcutaneous fat, and you were having overcompensation. This is not happening with non-thermal laser because we are not killing the fat. The fat is staying. We're just making the fat cell go from being unhealthy, hypertrophied, to healthy, lean, and anti-inflammatory. So you're not getting fat redistribution. These are the typical sorts of results that we would see in clinic after 4 to 6 weeks of treatment. We bring our patients back usually after 3 months, and I'm yet to see a patient who hasn't been happy with their results. But I think one of the really interesting things is the improvements in cellulite, which again, I didn't really believe until I saw it myself. Overall, how can non-thermal laser help with patients who are going through the menopause? It can help with a whole range of negative symptoms associated with the menopause. Yes, partly with weight gain, fat redistribution, and reduction in waist circumference, and so on. But it can also optimize general feelings of well-being. It can help to reduce the inflammatory profile and that chronic low-grade inflammation. It can help to optimize mitochondrial function. And we know there's this through a range of different studies looking at brain health as well, and how it can be used to decrease the inflammatory profile and response, and upregulate ATP production. So you have enhanced cellular function and enhanced energy, which means people show up as their best self. And they are not just surviving the menopause, but they're thriving. And in terms of neurological benefits, this is an area that has been explored and studied, but I understand that Erconia are now looking at are conducting studies at the moment about how this technology can support and help patients that have ADHD. So time will tell. These are some of the references. And if you want to ask me any questions, then please do stay in touch. This is my Instagram. This is my email address. You can email me. You can send me a message on Instagram when I'm not at work. I am with one of my 3 children that I was initially told I would never have. Thank you for listening.